It's time for another episode of the NRG Oncology Podcast. I'm Lauren Henke, and I'm joined by my co-host, Stephen Chun. Today, we are taking a dive into the world of endometrial cancer. Our guest is Dr. Edward Tanner, professor of gynecology at Johns Hopkins University and medical director of women's health in the National Capital Region. He is also the national principal investigator of NRG-CC010, which is looking to improve quality of life for women with early-stage endometrial cancer.
Dr. Tanner, thanks for joining us. Before we delve too much into CC010, I wanted to speak a little about the basics of endometrial cancer. While it's certainly not rare, there's about 60 to 70,000 cases in the United States each year. It's also not all that common. It's certainly not as common as breast, prostate, or even colorectal cancer. Since you are the medical director of women's health in the National Capital Region, what are the basics of endometrial cancer that every woman out there should know?
Thanks for having me today. It's really a privilege to be here to talk about our trial on endometrial cancer. As you mentioned, endometrial cancer it's certainly not rare. It isn't in the top three, but it is the most common gynecologic cancer. Unlike ovarian cancer, which is our second most common cancer and one that I think that more in the public people get some concerns about, uterine cancer does have symptoms, and we see that in patients having irregular bleeding or especially bleeding after menopause as an early sign of endometrial cancer. And because of that, unlike ovarian cancer, while there are some symptoms for that, they tend to be more subtle. With uterine cancer, if a person has bleeding, especially after menopause, they should be evaluated by their gynecologist. And under most circumstances, that would probably include a biopsy of the lining of the uterus and perhaps a pelvic ultrasound to see if there's anything of concern. And while a good proportion of patients with endometrial cancer are caught early, it is somewhat split between high risk and low risk cancers. And we see that in terms of the histology and grade of the tumors. So high grade tumors tend to have more aggressive pictures, but also, a lot of patients with low-grade tumors, we want to make sure they don't have high-risk features like spread to lymph nodes. So most patients with endometrial cancer are cured with a hysterectomy, but we want to figure out who the high-risk patients are who need more extensive treatments. And the status of the lymph nodes, whether they're spread or not, can really have a big impact on both prognosis and how we plan our treatments.
Early stage endometrial cancer is one of our triumphs in oncology, with the vast majority of women cured after hysterectomy and pelvic nodal dissection. I suspect many women just want it out and cured when they hear the words endometrial cancer, without maybe a lot of extended thought on the potential long-term quality of life considerations. But can you fill us in on the scope of quality of life issues after traditional hysterectomy and lymph node dissection?
I think this is something that we see a lot as oncologists, regardless of where our area of focus is, which is, in the very first meetings that people are really focused on, what do I need to do to be cured? And it's great to be able to tell patients who are diagnosed with endometrial cancer that they have an excellent chance of being cured. But it is important for us to discuss this issue. The main problem with quality of life for endometrial cancer is assessing lymph nodes. So traditionally, that would usually include a pelvic lymph node dissection, and sometimes higher up removing retroperitoneal lymph nodes. And just like some of our other more common cancers like breast cancer, where we see patients undergoing axillary lymph node dissections or removing lymph nodes from the armpit, when we remove lymph nodes, it can cause obstruction of the lymphatic drainage of the organs. And in this case, that means lymphedema or swelling in the legs. And that can cause both physical swelling, but also symptoms like heaviness and pain that causes problems with mobility and quality of life. And we know from a prior NRG trial of GOG 244, which was not a intervention study, but it was an observational study where patients underwent lymph node dissection for different types of gynecologic cancer, including uterine cancer, that at least 30% of patients who had a hysterectomy with lymph node dissection developed symptoms of lower extremity limb dysfunction and lymphedema after having pelvic lymph nodes removed. And that's really a big part of how we want to reduce the impact of these procedures, because most patients are cured and will live hopefully many years. And we want to limit the amount of impact on their quality of life by assessing lymph nodes. And GOG 244 really helped us to get there, but we needed to find ways to reduce the risk of lymphedema.
So, onto your clinical protocol, NRG-CC010, it looks like you're trying to compare traditional pelvic nodal dissection with sentinel lymph node mapping for endometrial cancer. When we talk about sentinel node mapping, can you tell us exactly what this is? And is this the same that's being done in breast cancer after lumpectomy, for example? Tell us about sentinel node mapping and the design of NRG CC010 and what you're trying to accomplish in this trial.
There are aspects of sentinel lymph node mapping that are similar for all diseases, whether it's melanoma or breast cancer or uterine or cervix cancer. And the main idea is that the goal is to identify the lymphatic drainage from the area where the tumor arises. So with breast or vulvar cancer, that usually includes injecting near or at the tumor site with a blue dye, and then using a radioactive tracer that's injected prior to the surgery and requires a gamma probe to essentially to identify the radioactive tracer in the lymph nodes. And that has worked really well for breast cancer. But it's a little bit simpler for uterine cancer, and that's because we don't have to worry about seeing through the thick structures of the skin. Because the uterus is an internal organ, we can inject into the cervix with a fluorescent dye called indocyanine green, and use a near infrared camera, and we can actually see the lymphatic channels going directly from the uterus on both sides directly to the lymph nodes in the pelvic sidewall. So unlike those breast cancer, we can really see the lymphatics all the way from where we inject to where the lymph nodes go to. And the other thing that's kind of interesting about it is with breast cancer, you have to inject where the tumor is. We looked at that initially years ago with the uterus, but you don't actually have to inject into the tumor because the drainage of the uterus is quite predictable. And we don't even have to inject into the uterus itself. We inject into the cervix, which is easily accessible with a speculum at the start of the surgery. And the mapping works really well and allows us to really identify one or two lymph nodes. And we have prior studies that have proven that the lymph node mapping is very accurate with very low rates of false negative mapping. So that's some of the data that we've built on for this trial. The big question with CC10 is that we didn't have data demonstrating that by performing sentinel lymph node mapping and just sampling one or two lymph nodes on either side rather than the full pelvic lymph node dissection, that actually reduced the rate of lower extremity limb dysfunction and lymphedema. So that's our hypothesis in CC10. We hypothesize that patients who are undergoing a minimally invasive hysterectomy and lymph node assessment will have lower rates of lower extremity limb dysfunction with sentinel lymph node mapping alone versus sentinel lymph node mapping with a lymph node dissection. So we have data from prior studies that we've used as our baseline, as I mentioned, GOG 244. And that helped us to establish what the baseline risk of limb dysfunction is, which are those symptoms that I mentioned before: limb heaviness, pain, and difficulty with ambulation. There's several domains that are assessed with this, and it's a fairly simple instrument. And we're able to follow patients over an 18-month period and look for a difference in their, it's called the GCLQ, or Gynecologic Cancer Lymphedema Questionnaire, and look for a difference in their GCLQ scores over an 18-month period. And we know that patients who have an increase in their GCLQ score of at least 4 points during that 18-month period, we would consider them to have a lower extremity limb dysfunction, which correlates with lymphedema. So it's a really unique trial. There are not a lot of randomized trials, surgical trials, that are powered with a quality of life endpoint rather than a survival endpoint. And we think that's really important because we already know from prior studies that removing normal appearing lymph nodes that have spread in them does not impact survival, which seems kind of counterintuitive, but it's identifying lymph node spread and then treating those patients with chemotherapy, perhaps radiation in some cases, that leads to better outcomes. So that's really the focus of the study. And as I mentioned, has a really novel patient-focused primary endpoint. And I'll just briefly mention one other thing that I think is really exciting. We do have a number of secondary and exploratory endpoints. We are looking at some of the test characteristics of sentinel node mapping in a real-world environment in community practice setting, and also looking at simple limb circumference measurements, bioimpedance, which is a way of looking at water displacement with essentially the same technology that you have in your bathroom scale, and some serum markers. And our hope is that we'll identify perhaps some early markers for patients who are going to develop lower extremity limb dysfunction and lymphedema with some of these secondary endpoints to help us design future trials. So perhaps, let's say, there's some serum marker that has a strong association with a patient developing lymphedema 6 months later. Perhaps this will help us to devise future intervention trials that we can intervene early to reduce the risk of patients developing lymphedema in the future. So that's pretty exciting too.
I really like how patient focused that this study is. Since I'm not a surgeon and have rarely, if ever, stepped into an operating room since medical school, can you give us some insight on how difficult it is to learn the technique of sentinel node mapping? How much of a learning curve is there to the technique? And what sort of quality assurance is in place in CC010 to make sure that the sentinel node sampling is done correctly?
Yeah, I think that's a great point. It's hard to do the kind of really high quality studies to determine the learning curve for surgical technique. In the data that we have, somewhere between 10 and 30 cases is considered adequate in terms of a surgeon's ability to accurately perform sentinel node mapping for gynecologic cancers. The protocol does have a minimum of 10 cases prior to surgeon participation. Given the protocol, I don't think that we likely have many surgeons who are close to that 10 case minimum. But that being said, one of the important parts of the study is that it's a community-based clinical trial. So prior studies that looked at sentinel node mapping in really expert centers, and as as an NCORE trial, we're really working on like community-based practice that it's really important that we look at this in a real world environment where perhaps not everyone is, an expert, but that's the way the real world is. And since half of the patients in the study will have a completion lymphadenectomy, we will be able to look at the accuracy of sentinel node mapping in that setting. But, I think one of the strengths of the study is that it's in a community setting where it's perhaps a mixture of experts and sort of perhaps not novices, but not experts performing the technique, which I think that's the way the world is. So I think that's a real strength of the study, is that we're looking at it that way.
I also noticed that NRG-CC010 is being conducted through a slightly different NRG oncology framework than the typical gynecologic oncology trial. Most commonly, for those of our listeners who aren't aware, when we see gynecologic oncology trials from the Gynecologic Oncology Core Committee, those trials begin with the letters GY, as in GYN. But in this case, the nomenclature, the letters before the trial are CC010. For example, you'd probably expect a trial like this to have nomenclature GY010 rather than CC010. You've kind of just alluded to why this is, but I was wondering if you could discuss in more detail what this pathway is. And that's, the reason there are these letters CC is because it was implemented through the NCORP pathway, or the NCI Community Outreach Program pathway. Tell us about the NCORP pathway and what made this trial appropriate for NCORP.
Yeah, that's a great question. I think that NCORE trials are really focused on delivery of cancer care in the community setting, which I think is very important for endometrial cancer, which is really, as we discussed, not the most common cancer, but is very common. This trial is really focused on community-based practice and on patient-centered care, which are both major components of the NCORE mandate. And when you look at NCORE trials and the CC trials, many of them are focused on quality of life endpoints rather than intervention studies with investigational drugs. And so I think that the NCORE pathway works really well for these kinds of quality of life focused cancer studies, while also recognizing that especially underrepresented minority groups and the NCORE community sites represent very well are very important for endometrial cancer because endometrial cancer disproportionately impacts Black women and other underrepresented minorities. So it's really important that we find ways to improve the quality of care for these patients in particular. And NCORE really allows us to do that in a way that gets to the kinds of patients that would most benefit from answering these questions. So I think it's a great mechanism. I'm really pleased that we were able to do the trial in this way. And I think it leads to the best possible patient population and the getting data for patients, the patients most affected by this disease.
This sounds like a really important trial for us to support through NRG Oncology. How far along are you with patient enrollment to this trial? And what has been the biggest barrier you've seen thus far to getting more patients to be part of the study?
Yeah, so we have accrued right about at 1/3 of the way through. We are definitely a bit behind on our accrual goals. Some of it was just a slow startup. We have really started to pick up, but we certainly could use more sites. If there are sites that are interested in participating, we'd be happy to have you. We have also recently opened the trial to Canadian sites, and I'm quite hopeful that we'll be able to open it in Korea soon. While I think those are great, we still would really want to continue our focus through NCORE and focusing on those populations, but we also want to make sure that the trial is completed in a timely fashion. So really some of the barriers have to do with a really wide variability in terms of how surgeons feel about the appropriateness of sentinel node mapping. There certainly are some surgeons that feel pretty comfortable doing this technique for low-grade endometrial cancers off trial, and others that feel uncomfortable with it for patients with high-grade tumors. One of the upsides of this study is that patients are stratified by tumor grade. So a site could say, I only would want to enroll high-grade patients. Is that going to be a problem? It's not at all. Or say a site only wants to enroll patients with low-grade tumors. All of that is acceptable. So I think that's been one of the things that we've tried to disseminate is that, look, you can enroll whichever patients you feel comfortable randomizing to sentinel nodes versus sentinel nodes with a full lymphadenectomy. And so I think that has helped. And I think that's been the main thing that we've tried to work through. And we have gotten more successful. We certainly would be, it's not too late to participate. If sites would like to get involved.
Well, Dr. Tanner, I want to thank you once again for joining us and ask for everyone's support of NRG-CC010. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect that of the National Institutes of Health. Thanks for tuning in, and happy clinical trials.